Hello students, welcome to the Pediatrics Pointers, your ultimate revision program in the Pediatrics. This is your faculty Dr. Ashutosh Aggarwal. The topic today we like to discuss is the childhood asthma. Now the first thing is, what are the clinical features which will make you suggest that in this question they are asking regarding the asthma is. There is presence of nocturnal cough or nocturnal worsening of the symptoms. There is presence of recurrent wheeze. Remember, a single wheeze can be due to an infection also. So if there is a presence of recurrent wheeze, that is a pointer. Personal or family history of allergic disorders, again a very important pointer. And presence of interval symptoms, that is wheeze is present without cough and cold. If there is only presence of wheeze, there is no cough, no cold, that is a pointer towards the asthma. To diagnose the asthma, you can go for spirometry, and on this spirometry you find there is low FEV1, right? So FEV1 is low, you tell to the parents this is asthma, they might not agree, you can go for the bronchodilator therapy test. So if there is a patient of asthma and you give bronchodilator therapy, there should be increase in FEV1 by more than 9 to 12%. Then you can also go for exercise challenge test. A person does the aerobic exercises for 6 to 8 minutes and there is decrease in FEV1 by more than or equal to 15%. Then there can be day to day or AM to PM variation of FEV1 which is more than or equal to 20%. So these are basically the criteria which can help you in the diagnosis of the asthma. Then we should know how to assess the severity of asthma. That is, asthma is boast of basically 4 categories: intermittent, mild persistent, moderate persistent, severe persistent. Intermittent is basically by the daytime symptoms. If we look at the frequency, it is less than or equal to 2 days per week. Nighttime less than or equal to 2 times per month, and FEV1 is more than 80%. Mild persistent, if you particularly look, daytime symptoms more than 2 days per week but not daily. Nighttime awakenings is 3 to 4 times per month, which is approx once in 7 days. This is approx once in 7 days, and FEV1 is more than or equal to 80%. Moderate persistent, daytime symptoms are almost daily. Nighttime awakenings is more than or equal to 2 times per week but not daily. That is approx once in 3 days. And FEV1 is 60 to 80%. And remember the word 60%, that will come in category of moderate, not severe. Severe is something which is less than 60. In the severe persistent, daytime symptoms are throughout the day. Nighttime awakenings are almost daily, and FEV1 is less than 60. Remember this. Now the principles of the asthma pharmacotherapy according to the Nelson 22nd edition, what we are teaching. Step 1, which is used for intermittent asthma, you are giving a short acting beta agonist plus inhaled corticosteroids. You are giving a short course for 5 days. Step 2 is for mild persistent asthma. There are 2 things you can go for. Either you will like to give the patient daily low dose inhaled corticosteroids or leukotriene modifying agents. Step 3 and 4, they are for moderate persistent asthma. In step 3, you are giving is daily low dose inhaled corticosteroids along with a long acting beta agonist. And in step 4, daily medium dose inhaled corticosteroids along with long acting beta agonist. Step 5 is severe persistent asthma, daily high dose of the inhaled corticosteroids plus long acting beta agonist. And step 6 we say severe persistent asthma. Again, in this what you are giving in step 5, that is daily high dose inhaled corticosteroids plus long acting beta agonist plus we are adding is the oral steroids. So if the patient is not getting benefit even with the oral steroids, then biological therapies can be added. They are added which is not in the severe persistent asthma, which is not controlled by steroids. What you should remember, at least the names: one is omalizumab, anti-IgE antibody; mepolzumab, anti-interleukin 5 antibody; dupilumab, anti-interleukin 4 receptor antibody. So what it does is, this basically inhibits both interleukin 4 and interleukin 13 production, and both of them are basically the activators for eosinophils. So this all three drugs can be given above the age of 6 years. Then there is benralizumab, anti-interleukin 5 receptor antibody. This binds to the anti-interleukin 5 receptor alpha subunit, and which results in apoptosis of eosinophils and basophils. But this is the one which is given about 12 years. So remember, there are 4 biological therapies. So out of these, 3 can be given above the age of 6 years, 1 is given above the age of 12 years. Then how to assess this severity of asthma in basically in acute attack of asthma. So acute attack, it can be mild, moderate and severe. In the mild, just remember, a child can lie down, child speak in sentences, saturation is more than 95% and the heart rate or pulse rate that is less than 100 is there. 4 things. He can easily lie down. Moderate means he prefers sitting. He speaks in phrases. The heart rate or pulse rate is 100 to 120. Saturation is 90 to 95. But if the child sits upright, not able to lie down, is just speaking in words, saturation is less than 90, pulse is more than 20, it is a severe attack of asthma. Right? What is the discharge criteria for a child of asthma? Again, according to the Nelson 22nd edition, sustained improvement in symptoms, normal physical finding, and this is something you should remember. Peak expiratory flow rate is more than 70% of predicted or personal best, and oxygen saturation is more than 92% while the patient is breathing room air for 4 hours. So this was in short a discussion of the topic of the childhood asthma. Do subscribe to the channel and keep watching the series Paediatrics Pointer, your ultimate revision program. Thanks.